Thank you for joining us today. My name is Mike Whitmer. I'm Vice President of NCMIC's Chiropractic Insurance Programs, and welcome to our webinar. Our guest today is Keith Henneman. Keith is Vice President of Claims at NCMIC. He's been working with malpractice claims for over 26 years, and there isn't much he and his team hasn't seen. So today we're going to be addressing some of the common questions NCMIC's claims department fields every day. Keith, thanks for taking time with us today.
Not a problem, Mike. Happy to be here and always happy to assist doctors of chiropractic to either avoid a claim if possible or to better navigate the situation if by chance they do end up having a claim made against them.
Great. Before we dive in, I do have a quick disclaimer to keep our compliance folks happy. This webinar is intended only to educate and inform. NCMIC does not set practice standards or standards of care. Information presented should not be construed as legal advice, as the presenters are not attorneys. If you have specific questions regarding potential malpractice risks associated with your practice or a treatment event, please call NCMIC Claims Hotline at 800-242-4052. So NCMIC receives questions from practicing doctors of chiropractic every day. Today's webinar will address several of the common issues we hear from our doctors, but if you have additional questions, please don't hesitate to give us a call at 800-242-4052. So let's dive into our first question. Are you ready, Keith?
I am. Bring it on.
All right, so from time to time, I find myself uncomfortable with a clinical situation, outcome, or patient behavior. I'd like to talk to someone experienced with clinical risk management, but I'm hesitant to call my malpractice insurance provider because I don't want a claim to be opened or my rates to go up. When should I call my malpractice insurance provider for advice on clinical risk management? Keith?
That's a great question, Mike. And usually what I tell doctors is, if anything doesn't sound right, feel right, or smell right, call your carrier. And so before you make that call, there's a couple things that you can do that are going to make that call more productive. So try to place in order, what you feel the issue is and how it was brought to your attention. So if it was another patient that maybe told you something they heard through the grapevine, what exactly did they tell you and how did they hear about it? If it was something that allegedly occurred during treatment, what part of the body were you providing treatment to and what type of adjustment? Was there a patient reaction, either verbally or was there something that you noted in your chart? Were there witnesses in the room or the treatment area? So that's going to make your call more productive with the claims adjuster. And the thing that's great about, I guess I can't speak for other carriers, but at NCMIC, as long as there isn't a lawsuit that's been filed against you or a demand made for damages, we treat these situations as an incident and it doesn't count as a claim against you. And so the thing that's great about this is if a claim eventually does get made against you, and that may be 6 months down the road, it may be 2 years down the road, when you call back in, you don't have to start from scratch and explain everything all over again to the adjuster that happens to answer the phone at that point, because we've already got that initial starting block and we can then go forward from there and see what exactly it is that we need to do for you.
Yeah, I think that there's a hesitation on the part of doctors to call because they think that it is going to be, negative noted on their file, and that's not the case at all. I always tell doctors we'd rather talk to you early rather than later and find out that actions were taken that are not in the doctor's best interest long term. So
no, that's a really great point, Mike. And actually, there are a lot of situations with maybe some suggested wording for a conversation or a suggested reply to an email that we can cut off some of these situations, we'll call them, from actually becoming a claim. So this is kind of part of the value add of your premium. It doesn't cost you anything to call us and hash things out. And to your point, we would definitely prefer that you do that ahead of time instead of trying to handle it on your own and potentially make a situation more difficult than it really needs to be.
Okay, great. Let's move on. Next question. What should I keep in mind when talking with a patient who has expressed dissatisfaction with the care they received or experienced a bad outcome? Should I apologize to my patient?
So this is another really good question, and one that we get frequently. So I'm going to kind of chop this up into two different scenarios. So the first part is the dissatisfied patient. Why are they dissatisfied? Is the treatment taking longer than you said it was going to take? Are they not getting back to work in the amount of time that you said they were going to get back to work? Are restrictions that you suggested to them, stretching on longer than you originally discussed? So in other words, the dissatisfied patient, you need to kind of do a little dissecting of, why aren't things going as planned? Is the patient being non-compliant with your treatment plan? Are they, maybe you say, let's start out coming in twice a week for 3 weeks and then we'll reassess you. Are they just coming in as needed? And that may be, once a month. So you're always starting from ground zero. So a dissatisfied patient, you may actually have to have kind of a little difficult conversation with your patient and find out, are they part of the problem by not being compliant, or is this something that maybe was a little bit more in depth than you had originally thought you were dealing with? So now a bad outcome, that kind of gets into a situation where you may need to make a decision whether to apologize or not. And so when you start going down that road, this is another situation where give us a call and we can kind of talk through and walk through what you may need to do here. But in general, one thing you need to keep in mind is, what are the laws in your state regarding apologizing? As it stands right now, there are over 30 states that have laws that are known as I'm sorry laws, and a few states actually have mandatory disclosure notices if there is a bad outcome to a treatment situation. So what an I'm sorry law means is, if you're in a state that has one of those, if you apologize to a patient in any form or fashion, that can't be used against you later as an admission of guilt or fault. So the states that don't have this, you probably don't want to offer an apology because it could be used against you as a situation where they can say, well, you apologize, doctor, so therefore you must have done something wrong. So that's why when we started this conversation, I initially said, call in and talk with us and we'll let you know the best way to go. So now, if you are in one of those 30 states that I referenced, one thing to consider is how are you going to handle this? So before you meet with the patient, it's good to sort of get the facts surrounding what the issue was before you, so that you're fully informed about what happened and be ready to discuss it. So this conversation that you're going to have with your patient isn't the time to be guessing and discussing hypotheticals with them that could potentially lead to additional questions or maybe even further retractions. This is a time for transparency about, here's what I was trying to do, here's what happened, I'm sorry for what happened, and here's what we can do to potentially remedy the situation. Now, remedies to a situation, that could be a whole webinar all in and of itself, so we're just going to kind of leave that right there. But that would be part of the conversation when you called in to say, hey, what do I do? We would go into that. I'm not going to go down that trail today, but a couple things to keep in mind when you have this meeting with the patient and or their family. Don't, if they want to bring somebody with them, encourage them to do that. But then when you're having this meeting, there's a couple things I want you to keep in mind. And the first thing is the old saying that we have 2 ears and 1 mouth for a reason. So don't interrupt the patient, be attentive and take notes as to points that you might want to clarify when they're done speaking. So once they are done, share what your perspective is of what happened, and it's okay to disagree with the patient's perception. So, but if you do this, do it empathetically and not combatively. This situation isn't where somebody's going to be right or somebody's going to be wrong, and it's not about who's going to win and who's going to lose. So patients and ultimately juries want to see a doctor that is human, that's compassionate and caring about their patient, and not someone who's trying to come off as they can do no wrong and are untouchable. So once your conversation is done with the patient, however that concludes, then it's time to document. Just like treatment, you want to document this conversation, what was said, what was agreed to. And the thing that's going to be a little bit different about this documentation, this isn't going to go in the patient chart. This is going to go in a separate file that you're going to set up. You can call it whatever you want, but you need to know where that chart is. And the reason I'm suggesting you put that in a separate chart is that if your practice is like most practices, if a records request happens to come in on this particular patient, your staff usually handles those. So you don't want that conversation being sent out to other providers potentially, because all they're going to see then is, oh, this doctor caused this injury, and then that's going to become part of the continuing narrative that transpires after treatment that you rendered. So that's why I suggest you don't put it in the patient chart.
Okay, good advice. I think that a lot of times, patients, they're looking for empathy. They're looking for that caring doctor, and this conversation could be a tool for that.
Oh, absolutely. And there are all kinds of studies out there that talk about doctors that have good communication skills are less likely to have a claim or a lawsuit against them than doctors that have poor communication skills.
Sure.
And so they're willing to give you the benefit of the doubt as long as you're upfront and keep them informed about what's going on.
Yep. Okay, thank you. All right, next question. Rib fractures are a common risk of care. How can I prevent rib fractures from happening in the first place? If I do fracture a rib during treatment of a patient, what should I do?
Sure, it's probably, I guess I won't say one of the more common claims that we see, but it does happen. So especially if you're treating an elderly female patient, you may want to ask a couple additional questions. What sort of medications are they on that may decrease their bone density? When was the last time that maybe they got a DEXA scan, which actually looks at what their actual bone density is? Is it someone that if they fall into that category and they actually tell you that, I do have osteoporosis or osteopenia, maybe it's somebody that you do an instrument adjustment like an activator to instead of a manual adjustment. Certainly, you should give some serious consideration to backing off whatever your normal pressure is. And while I say that, and one of the common complaints in these sorts of claims is that, well, it was a more forceful adjustment than it was previously. So from a patient's perspective, I consider that a very subjective, but to well-experienced practitioners, they all know exactly how much force they're providing in the adjustment. So maybe if you have an elderly female patient or even a male patient, it's not quite as prevalent as males and females, but there still can be some bone density issues. Maybe just dial it back a little bit. And I've also been told over the years from doctors that when a rib fracture happens during treatment, that both the patient and the doctor knows that it happened because it sounds different and it apparently feels different. So I can't personally speak to any experience on that, but I've had dozens of doctors over the years tell me that. In fact, usually those conversations when they call, they'll be like, it's not even, I think I broke a rib, it's, I broke a patient's rib today, so what do I need to do? So ask questions and consider maybe different modalities of treatment if you've got somebody that you think may be at a higher risk for a fracture.
Sure. So let's say a fracture happens during treatment. What should the doctor do?
So first of all, make sure the patient is okay. Ask them if, assist them getting up, ask them, how they're feeling, where it hurts. If you have x-ray equipment, it may be a situation where you get an x-ray to confirm, even though it may not show up right away. Um, if nothing else, that's going to show kind of that next level of care and compassion that you are confirming what you think may have happened. And then, go from there. The thing with rib fractures is there isn't a whole lot that can be done for treating them. It's just time and patience. But the one thing you do want to make sure that the fracture isn't displaced, which then, could be some complications related to that or associated with that, versus the vast majority of rib fractures are non-displaced, which just basically means the bone's still in its anatomical correct position, but it's got, a small crack in it, versus being separated and maybe malaligned, which may need some further assistance and potentially referral to an outside, maybe an orthopedic surgeon, to take a look at what's going on or how they can get that back in alignment.
Sure. I think that the rib fracture situation is a prime example of how effective patient communication can make a big difference in how this plays out. I've talked to doctors who have fractured ribs, and maybe they freak out a little bit. And they don't do that follow-up. They don't have that follow-up conversation. They try to get rid of the patient as quickly as they can. And now we've got a patient that's had a bad outcome, but we also have a patient that's going to be upset and mad.
No, that's very true, and not to minimize a situation where somebody had an unintended consequence to a treatment, but think about if you have kids and you're a parent and they fall and something happens to them, they instantly look to you and how you're going to react. So if you've treated somebody and you know that you fractured their rib and you start freaking out, your patient's going to freak out just as well, and then you've got a situation that went from manageable to almost a borderline, potentially crisis situation where, who's going to calm who down. So remember that you're the medical professional, and, in the difficult times, it's very important that you act calm, cool, and collected, because your patient's going to look to you for guidance about, okay, so how are we going to deal with this situation, and what do I need to do and what are you going to do? And then I think I may have missed this, but probably the most important thing, if this situation happens, call your carrier again, give us a call. We've got tons of experience in dealing with fractures, rib fractures, and can walk you through how to handle it, what to do, what not to do, and what to say and what not to say.
Yep, good advice. Kind of tying back to what we were talking about earlier. Call your malpractice insurance carrier. In this situation, should you apologize? So all of that
Right,
wraps into this as well. So
right,
okay, thanks. Let's move on to the next one. I
sure.
have a patient who is flirtatious with me. What should I do?
So I think that people might be a little tired of hearing me talk, and I think I know you have maybe a little bit more experience on this, Mike, than I do. So do you want to handle this one?
Sure. The advice that I give to doctors when they're faced with a flirtatious patient is that they probably need to discontinue care of that patient. So refer them to a trusted colleague, probably of the opposite gender of what you are having issues with, and then follow guidance as far as avoiding patient abandonment and everything that goes along with that as well. So doctors are always hesitant to discontinue care of patients, and for good reasons. But when you have a patient in your office that is not being respectful of the boundaries inherent within the doctor-patient relationship, that poses enormous risk to the doctor, to the patient, and everybody involved. So probably the best step that can be taken is to discontinue care of that patient, give them the time and the options to develop care with another provider, but it's extremely risky to keep them in your practice.
No, those are all really good points. And I think you brought up, one point that I know, just like there's some hesitancy from doctors to call their malpractice carrier because they think, they'll get the proverbial black mark. Sometimes there are situations when terminating a patient from your practice is exactly the right thing to do. And this is one of those situations where I would agree wholeheartedly with what you said, that to protect yourself and your reputation and your practice's reputation, this is definitely one of those situations where you need to give that some serious consideration, no doubt.
Yeah, okay, thanks. Okay, another boundaries related question. I'm single and new to my community. Most of the people I meet through my practice. When is it appropriate to ask a patient out or accept their invitation to see each other socially?
Sure. So I guess the short answer to this, based upon situations that we've seen, is never. Now, we got a few situations here where it says, to see each other socially. So if you have, open house at your practice, or other social events that you sponsor in the community, that's one thing. If it's, hey, the office is having a happy hour on Friday and patients are invited as well, or maybe it's like the last couple patients that happen to hear the staff talking about, hey, we're going to such and such a place for happy hour, that starts to really get into that gray and fuzzy area of, is this a professional doctor-patient relationship, or is it more social? And that can lead to a lot of situations where there's confusion about, what is acceptable to talk about or to not talk about. So generally speaking, if you call in and talk with me or one of my team, generally we're going to just tell you just flat out, this is a bad situation and would encourage you not to do it. I understand that, especially if you're practicing in a small town, that may sort of crimp your social circle to a certain extent, for lack of a better phrase. But in the long run, I think you're going to be in a better spot not having to deal with the fallout of, so maybe you decide to date someone that was a former patient, which in some states, after a certain amount of period, that is acceptable. But then, you have a bad breakup. So then you get into the whole situation of, are they going to start bad mouthing you around town? And how do you deal with that? So the best way to deal with that is to just not let it happen in the first place. And, there are obviously other ways that you can, deal with your social life outside of the people that may be part of your practice. And I'd encourage you to definitely look into a bigger pool of potential candidates for dating and social experiences outside of your patient base. It's just too risky and fraught with pitfalls from start to finish.
Absolutely. Whenever I'm talking to students, in the classroom, I ask the question, when is it appropriate to date a patient? And the only correct answer on that is never. And and the reason for that is the risk that it poses to the practice, but probably more importantly is the impact on that patient. And the inappropriate nature of that relationship is because of the imbalance of power and the fiduciary responsibility for the doctor within the doctor-patient relationship. That has to take precedence before anything else, including and especially your personal needs, desires to have a dating relationship.
No, those are all good points too, Mike, and usually kind of one of the first pitfalls of, you know, the treatment part of this, if you decide to have one of these relationships, is record keeping usually goes out the window, and where treatment may be rendered starts to be more outside of the office than in the office. And again, that just leads to a whole situation where it's going to be hard to explain and support if a claim comes of that situation. So again, you know, the short, easy answer to this question that we've been talking about for quite some time now is it's just generally never acceptable or a good situation to date one of your patients.
Right. Okay. Thank you. All right. Next one, also in the boundaries area, my office is an open environment. Are there risks? Are there risk management concerns I need to address with an open office environment? And I think that what we're talking about here, Keith, is, you know, open bay adjusting and things like that, where the office
Sure.
is very open, and, you know, if I'm a patient, I walk in, I can see patients being treated and that sort of thing. Are there concerns with that, and how do you manage those concerns and those risks?
Sure. So, you know, from a boundaries perspective, if you want to talk about you know, sexual boundaries, actually having an open bay concept may be a pretty good form of protection, because there's no doors to close, there's no walls to hide anything, and literally everything is out in the open. So probably one of the biggest risk management concerns that you need to deal with an open bay treatment area is HIPAA compliance. So I strongly suggest that you have an office that you can go and have a pre-treatment consultation with the patient if you need to, where you're going to talk about very specific things. And when you are in the treatment area, only use, you know, first names. Don't use any sort of personal identifiers with where another patient can maybe, you know, figure out who this patient is, and what their situation you're treating, and, you know, any other personal health information that is protected by HIPAA. So that's probably the biggest thing, but as long as you have that option to go have the consultation in a closed situation with the patient to discuss that, you know, just be cognizant of using personal identifiers that could potentially be a HIPAA violation.
Sure. Okay. Thank you. All right. Let's move on to documentation, always a hot topic in risk management.
Yes.
Documentation is always a challenge for my practice. What do I need to be documenting from a risk management perspective to protect my practice? Are there special considerations for electronic health records?
So let's take the first part of this.
Sure.
So what needs to be documented? So the one thing I'm not going to tell you today is how to take notes. I know that notes are drilled into your heads when you're in college, and we insure a pretty decent number of the chiropractic colleges, and every once in a blue moon, you know, we'll get a claim that comes in from the clinic there, and the chart is so thick, it's ridiculous, because, you know, if you don't chart properly, you're not going to pass. But when you get out into private practice, I get that time is money, and where managed care is, the reimbursements aren't that great. And so you need to see more patients to remain profitable. And one of the first things to go is the quality of your note taking. I get that. So probably the most basic and recognized format is the SOAP format. And I'm not saying you need to use the SOAP format, but I'm just going to use that for the purposes of this example. So the basics that you need to have in there are the subjective patient complaints. So, why are they coming to see you? What are your objective findings? And then what's your assessment and what's your treatment plan? So there are going to be variations of this, and you may have your own format that works great for you. And the one thing that I'm going to encourage you to do is whatever your format is, that needs to be consistent throughout the treatment plan of a patient and for all your patients. So it's not, you don't need to do a full thorough examination every time somebody comes in, but you should have, points in your treatment plan where you're going to do a reevaluation if somebody's not getting better, or they have, setbacks or something in the treatment plan. So another thing that you need to keep in mind is that, if a treatment event occurs today, you may not be made aware of it until 18 to 24 months down the road. So the one thing I always advise doctors is, if you have to try and explain what happened 2 years from now, are your records going to be your best friend, or are they going to be your worst enemy? So I get that, every time somebody comes to see you, you don't need to write a novel, but you need to have enough in your chart to know what you did, where you did it, and why you did it. If you cover those 3 things, you're probably going to be okay if you have to explain yourself in a deposition at some point down the road. If you've got very sparse notes and, the best you can do is, I'm not sure, but my usual practice is this, but what your usual practice isn't notated in your notes, then you're going to come across potentially as incompetent or sloppy at best. So keep that in mind. Always think about, am I going to be able to support what I did if I have to in front of a jury?
Sure.
So generally my scenarios are worst case scenario, but I get that, time sometimes doesn't allow that, but do the best you can at the end of the day.
I think that risk management is a term that gets thrown around a lot, but at the end of the day, I think good risk management is good patient care.
Yes.
And good patient care is good risk management. And
Right.
documentation is no exception. We preach all the time that you need to keep good records because of these risk management issues. But at the end of the day, it really is about patient care. You want to have good, complete notes so that when that patient comes in the next time, you know what's happened. Also, if you need to refer that patient out, the provider you're referring to will then have the benefit of all the work you've done with the patient and be able to provide a better level of care. So yes, good documentation is good risk management, but it's good patient care first. So go ahead, Keith.
I was just going to say that's a really great point, Mike, no doubt.
So are there any special considerations for electronic health records?
Sure. So the biggest thing with the electronic records, so there's a lot of programs out there, and if you decide to go that route, which most practitioners are there or certainly close to getting there these days, and you need to find a system that works for the way you practice. So I'm not going to tell you that one system is better than another, but here's the biggest concern that we see with electronic medical records is, and this concern usually sort of rears its head if you're in a group setting or you have a practice where you have multiple locations and then you have doctors that rotate through those clinics on various days in the week. So before you hit enter, submit, or send, or whatever the executing function is to lock your note in, make sure that you're the provider listed as providing the treatment on that day for that patient. It's not uncommon for us to have a situation where one doctor will have a claim made against them, or in some instances actually have a suit filed against them. And then as we get the records and we start going through it, they say, you know, well, this was on a Tuesday at the ABC clinic, and on Tuesdays I'm at the XYZ clinic. So there's no way that I could have provided treatment to this patient on this day. Tuesdays is usually Dr. Johnson's day here. So we need to check the schedule and see if Dr. Johnson was actually at this clinic on that day. And again, that's going to get back to, you know, how professional does, you know, do either you and or your group look if, you know, nobody's taken the time it takes to actually list themselves as the provider in the records. And then, you know, the other thing with electronic records to keep in mind is there is this little term called metadata. So the metadata is what you can't see that's going on in the program for your health records or for the electronic records, that is noting every addition, every transaction, every deletion, anything that is going on in that chart can be tracked. So you might think you deleted something or that you added something, and maybe you, after you get a records request, you know, it's very common to go back and look at the chart and say, oh, I remember this happened, and you try to add it on the date that it occurred. So that date may still stay as 2 years ago, but if somebody asks to do a metadata sweep, which is very common these days, that may show up as, you know, if it were today's date, March 3rd, 2021, as when that addition was made. That's a tough situation to explain away. So
Sure.
know that for everything great that comes with medical records, there are some potential pitfalls as well that you just need to kind of be cognizant of.
Okay. All right. Thank you. So next question. I talk to my patients about the benefits and risks of care on an ongoing basis, but usually these conversations are very casual. What should I be documenting with respect to informed consent? Big issue.
Big issue. So the biggest thing to take into consideration with informed consent is, first of all, know what your state requires. In some states, it's mandatory that you provide your patient with informed consent. In other states, and this is a really unique situation, but it's one that I always use, is the state of Pennsylvania has the requirement that informed consent only applies to invasive procedures. So very specific to chiropractic, obviously there are no invasive procedures, so it doesn't apply. That doesn't mean you can't do it. And if you are going to do it, there are some things that you definitely need to make sure that you take into consideration. So we fondly say around NCMIC that informed consent isn't just a form, it's a process, and it should be a process because it's about the treatment that you're going to be recommending that your patient goes under, and they have the right to make a decision whether or not they're going to agree to the treatment plan that you're presenting them. So informed consent isn't having your front office staff have the patient complete a form when they come in to check in, and then the form goes to the file. And it's never discussed again, never looked at, never talked about. Informed consent is having the patient fill out that form, and then you asking the patient after you go over what your treatment plan is, if they have any questions or concerns about it. What happens if they don't go forward with your treatment plan? What are some alternative options if they're not quite sure about it? That conversation should be documented in the chart, and that can go a long ways to literally running off a claim if something were to happen down the road. Because generally what happens is if a claim gets made, a patient will say, well, if the doctor would have told me that, that was a potential side effect, there's no way that I would have authorized them to provide that treatment to me. If you've got proof that you had the conversation with the patient, both a signed form that lists potential side effects, and then the documentation in the chart that you had that conversation, that's going to be a really hard hill for the plaintiff to get over to continue with their claim against you, if ultimately that's where a situation ends up.
Sure. How often do we see claims that involve an allegation of lack of informed consent or negligent failure to inform?
I would say I'm going to answer this two ways. Previous to about 5 to 7 years ago, it actually was pretty rare, but of late, it's actually more rare that that's not an allegation. So in almost every certainly lawsuit that gets filed, there's some form or variation of an informed consent allegation in there. So it is important, and so it definitely is something that we deal with on almost every single claim.
Yeah, so very important.
Very important,
All
no
right.
doubt.
All right. I practice in an area with a large retiree community, so many of my patients are elderly. Many also have difficulty with mobility. How do I ensure a safe environment for my older patients? I think that when we were talking earlier, Keith, about the rib fractures, that's certainly part of it, but there's other issues as well, right?
That's correct, Mike. And so if you have, whether it's, one or two elderly patients, or you actually have a large percentage of your practice that are elderly patients, there's a couple things to keep in mind. First of all, you're going to know how mobile your patients are, especially if they're well-established patients. And, don't hesitate to, don't automatically, grab onto somebody's arm and help them up. Ask them if they would like some assistance getting up or getting down to the table. Then that's actually a form of consent in that particular situation. And then if they do or don't, then abide by those, their wishes. But if somebody doesn't want you to assist them getting up or down and you have some concerns, don't turn your back until they're securely either down on the table or they're up on their 2 feet and you're sure that nothing's going to happen. Because every once in a while we do have a situation where somebody gets up and maybe they got up too fast and they get a little bit lightheaded and they'll fall down. We get maybe one or two of those claims a year, and in those situations it's not always an elderly patient, but it generally is, and those can lead to fractured clavicles, fractured hips. We've had some knee injuries over the years, so really just be a little bit more cognizant of how your patient's getting around the room, especially when you ask them to change positions, or if you ask them or treatment's over and they get up and they're getting ready to leave. Just make sure they get to where they need to go and be a little bit more cognizant of all of their movements while they're in your custody and control in the treatment room.
Okay, thank you. All right. That's it. Thanks, Keith, so much for helping us understand some of the best practices and sharing your insights from your many, many years working with malpractice claims. We really appreciate it. And thank you to our listeners. If you have any other questions, please feel free to give us a call. Again, that number is 800-242-4052. Before we go, I do have a few quick reminders. First, NCMIC is presenting monthly webinars on a variety of risk management topics. All our webinars are recorded and the recordings are posted in the resources section of ncmic.com. While there, be sure to check out all the other resources that we have available. We are continually adding to our content with information to help you navigate daily practice and deal with the challenges that you face. We have information out there on a wide variety of topics, including COVID issues and risk management, so please check that out. NCMIC also has a podcast called Chiropractical. We use the podcast to talk about current issues in healthcare and give you actionable information for your practice. You can download the podcast at ncmic.com or wherever you get your podcasts. You can also keep up to date on new resources from NCMIC by following us on Facebook, Twitter, Instagram, and LinkedIn. So once again, thank you, Keith, for joining us, and thanks to our listeners for joining us. I hope you can join us for future webinars. So once again, thanks, Keith.
Thanks, Mike.